Okay, this time we're going to be talking about the spectrum of healthcare and healthcare delivery. The unit objectives for this is to differentiate between the health and illness definitions and the impact that lifestyle and the risk factors have on one's health status. We're going to define terms like health promotion, wellness, and discuss the nurse's role. We're going to differentiate between primary, secondary, and tertiary care, as well as the role of the nurse when providing these levels of care. We're going to talk about the goals of acute and chronic care and examples of client conditions for each of these. We're going to discuss principles of restorative and rehabilitative care, its goals, and the role of the nurse in these. Compare and contrast palliative and hospice care and the role of the nurse in providing end-of-life care. I do want to put a little side note here. We're going to really address this in depth in a separate micro lecture. This will be the loss, grief, and end-of-life micro lecture, which we'll prepare after this. So if we don't talk that much about it, don't worry, we're going to cover that in depth. We're going to describe the various healthcare settings where client care is provided, and we're going to discuss the roles of state and federal government in regulating these healthcare facilities. Okay, now we're going to talk a little bit about health and illness itself. Health is going to, of course, mean different things to different people. It's supposed to include the absence of disease as well as optimum functioning on every level. By every level, we mean closer to the Dorland Dictionary definition, a state of optimal physical, mental, and social well-being. The popular idea that it is merely an absence of disease and infirmity is not complete. So we're going to lean more towards a holistic care of the whole person as nurses. It's important to define what you believe health and illness is because your perception of these terms influences what you say and what you do when you care for your patients as a nurse. Culture, education, and social influences, things that you were brought up with, will influence these things. Okay, so take a look at this slide, this caricature. This fellow looks like he's been pretty well fed. Would we consider this gentleman to be healthy by today's standards here in the United States? Probably not. But there was a time when obesity was considered to be kind of a sign of prosperity, to be well fed, a sign of wealth perhaps, as opposed to being poor, thin, and gaunt looking. This was desirable over the skinny picture that you see. How about this lady? Now, this is an extreme example, of course, but I just use this to point out that social media continues to encourage people to see the very thin and even dangerously thin people as beautiful. Most supermodels are exceptionally thin, to the point it's very unrealistic and even unhealthy. Cultural influences on concepts of health and illness. So there's a great cultural diversity in the United States, and that brings many differences between the values and practices of the different ethnic and minority groups. Racial and ethnic differences apparent in attitudes and practices. These show up in things like birth, death, and general health care. Susceptibility to a specific disease, what culture you are, your background will have a lot of influence on how susceptible you are inherently to certain diseases. Responses to pain and suffering, even just how a different culture would respond to pain. Are we encouraged to be stoic and quiet? Are we encouraged to verbalize our feelings? It can vary very greatly from one part of the country to the next, as well as one country to the next. Personal hygiene and sense of privacy. Different areas of the world have different conveniences and hygiene practices. Privacy, your sense of personal space, just how close people are allowed to be when they're talking to you. You've heard the term close talker. People can be very uncomfortable from some cultures if you're too close to them when talking. They don't want to be within a certain, so many feet It's invading their personal space, while others, they don't have that sense of personal space and they're more touchy-feely, more physical contact is invited. Adjustments to lifestyle, adjustments to life changes. Some cultures are used to just rolling with it and, constant change, and other cultures they like the routine. They don't like a lot of change. Many cultures have their own healers. There can be a medicine man, a shaman, or a curandero. I don't think I said that right. And these people may wish to consult their traditional healer before they go to a licensed professional, just a practice that they've grown up with. Respect for these cultural beliefs is required to maintain a client's trust. They're probably going to seek out these cultural medicine people for advice and patient education that may or may not be beneficial to their situation. So you have to kind of weigh these things carefully. And again, you want to respect that person's cultural beliefs without insulting the way they've been raised. Health literacy. What do we mean by health literacy? This can affect how the patient's outcome comes about. Health literacy is the knowledge and skill in making healthcare decisions. Many cultures have beliefs that are based on folk medicine. Folk medicine, or information that's passed down from generation to generation within that culture. There again, without insulting the way they've been brought up, you want to bring attention to the evidence-based practices that we have now, based on evidence. This is the way we do it. This is why. Be sure that you are correct in the evidence-based evidence basis that you're presenting your information from. Now we're going to look a little bit more at the traditional views of health and illness. Traditional views meaning what we're used to. Primary illness is usually what develops without being caused by another health problem. So an example of this would be maybe diabetes. Person may have been diabetic since a very young age, or diabetes type 1. This can lead to a lot of other health problems or secondary illnesses later in life. Another primary illness could be heart disease or atherosclerosis, that hardening of the arteries that can lead to a lot of other complications later in life or secondary illnesses. Peripheral vascular disease resulting from diabetes is an example of the secondary illness starting from diabetes. Some diseases are inherited or inherent, genetic or congenital, present at birth. Sickle cell anemia is an inherited disease. Cultures, African, a lot of those cultures have more people that suffer from this type of disease than, say, Caucasian European descent. Idiopathic illness is something else you need to be aware of. And idiopathic illness is something that's a disease for which there's no known etiology or cause. They're not really sure where it comes from. It's just kind of a fluke. We've got the different kinds of illness here, portrayed as the chronic illness, acute illness, and terminal illness. This goes on to say the chronic develops slowly over a long period of time, lasts throughout the life. Acute is something that happens all of a sudden and just it hopefully resolves in a short time. A terminal illness is one which there's no cure and usually ends in death. A terminal illness usually is defined as, well, you can be on hospice if it's less than 6 months expected potential to live beyond. Usually they die within 6 months if they're considered terminal and be put on hospice care. People that influence the traditional view of health in the Western culture are the old school people like Plato, Aristotle, and the other philosophers that were concerned with only biologic well-being. For many years, an acceptable definition of health in the Western culture was simply the absence of disease. It's worth pointing out in 1946, the World Health Organization redefined health as the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And eventually a more holistic approach was embraced, treatment of the whole person, mind and body, or holistic care. This talks about the holistic approach. It is spelled funny, whole without a W here, whereas the whole person is spelled W-H-O-L-E, but holistic approach. Nurses take a holistic approach to caring for the sick and promoting wellness. Considers biologic, psychological, sociological, and spiritual needs. Acupuncture, acupressure, biofeedback, meditation, and various relaxation techniques are some examples of this more non-traditional medicine or holistic care. The holistic approach to healing the person is the central focus, not the illness or the injury. Things that influence our basic beliefs about other humans and our relationships with them are the value we place on human life, our ability to deal with sickness and health, and our decisions about how to behave toward other people. This is kind of just a picture that shows an example of acupuncture. There's certain, for lack of a better word, pressure points, or maybe trigger points would be a better word, where the pins are inserted percutaneously or through the skin into like little nerve trigger point spots to relieve the symptoms that the patient is experiencing. Again, this is both physical, mental, and spiritual. Stages of illness. When people are experiencing illnesses, they act in different ways. These are called illness behaviors. Fear of what the problem might lead to, or what the problem might be, or what to expect undergoing exam and diagnostic procedures can often cause people to be very anxious. During convalescence or recovery from a chronic illness, total recovery is often replaced by either adaptation or adjustment, or maladaptation or lack of adjustment. So when an illness would occur, there's a transition stage. You may not really feel ill, but you recognize something's not right. Eventually there's an acceptance stage, like something is wrong. You acknowledge the illness and you want to take measures to make it better or to become well again or to get back to your baseline. And then there's the convalescence stage, the actual stage where you're trying to recover from the illness and regain your health. You may or may not achieve the baseline from which it started, but you want to get the optimal health possible. Here's a spectrum example of healthcare spectrum, I guess. In general, being healthy means being able to function well physically and mentally and to express the full range of one's potential within one's environment. So here we're going to show you the spectrum from normal functioning, healthy, to mild, common, and reversible stress, like temporary stress from an exam, or your car breaks down, but it's temporary. This is something that's fixable. Then there's moderate, a significant functional impairment. This could be a significant relationship breakup, or maybe a death in the family of an immediate loved one. This is a moderate stressor and it may last for a while. Financial pressures, they can go on for quite a while, but they do kind of eat into your health a little bit. Then there is a severe impingement on your health here. This is when severe and persistent functional impairment like depression, anxiety, PTSD. What do we mean by PTSD? Post-traumatic stress disorder. This is usually something that's several months after the event that continues to plague the person and their health. Current views of health, health evaluated on a graduated scale. This is your continuous spectrum. This ranges from obvious disease through absence of disease to a state of optimum functioning in every aspect of life. Here we're going to start talking about Maslow's theory of basic needs. This is presented on a hierarchy. They usually use a pyramid to show the example of Maslow's hierarchy of basic needs as an explanation for the things that motivate human behavior. On the bottom of this pyramid, you're going to have things that are very, very basic and that you have to fulfill before you can move up the pyramid to achieve the next level. Things on the base or the bottom, the supporting foundation, are things like physical needs, food, air, water, rest. These must be satisfied before you get to the emotional needs that also want to be satisfied. You have to have these things before you move up the pyramid. This is used to determine priorities of nursing care. So when we ask you to prioritize your nursing issues or the problems you've identified, you come up with nursing hypothesis, you always start with the basic needs first. A lot of times we'll say ABCs, airway, breathing, circulation. Then we graduate to the Maslow's hierarchy of needs, food, water, rest, and then you continue upward toward the emotional levels, which I'll show you an example of this here shortly. It takes into account the social needs of the person and the individual in acute illness. The ones that are most often compromised are the physiologic during the acute phase. In the chronic illness, all of them may be effective. So higher on up the pyramid, you may have more effects. Again, with the Maslow's theory of basic needs, we've got physiologic needs on the bottom. Fundamental needs, physical needs are essential to maintain life. Then you move up to security and belonging. Security for the patient depends on reassurance that their physiologic and safety needs are met. You really can't move on until you're sure about that. Each person needs to feel that they belong or is attached to others. Here's that pyramid. This kind of demonstrates very clearly the physiologic needs at the bottom. Then you've got to have safety. You have to feel safe and secure that these needs are going to be provided before you move up to love and belonging. And eventually, if this stays in place and stable, then you can move up to some self-esteem, respect. And finally, the cherry on top here is the self-actualization. This is, some people never really achieve this level, but hopefully you get to achieve that level as these needs are satisfied. Here's a big word for you, homeostasis. Stasis means to be static or to stay the same. Biologic systems maintain stability of internal environment by continually adjusting. Your body has to continually make adjustments necessary for survival. Wellness maintained or regained when one is able to keep a sense of balance while adapting to factors that can upset that balance. Stress, whether they're temporary or chronic, will disturb that homeostasis and causes the body to adjust or attempt to adapt. That adaptation is called homeostasis, trying to maintain that level of well-being, trying to maintain the status quo. One must adapt to factors in the external environment. Adaptation that results in illness and is an adaptation that results in illness, like you adapt, but it causes you to have a problem, is called maladaptation or poor adaptation. These are those stages of general adaptation syndrome. This is a syndrome where initially you have alarm, then there's resistance, you try to persevere, but eventually your body wears out and you give into exhaustion. This is called general adaptation syndrome. Adaptation, which is normal during homeostasis, your body tries to adapt. It's a response to the change. The body systems have to self-regulate to maintain the homeostasis. It requires a pathway of communication between the brain and the various body systems. You may or may not be aware that this is even going on. It involves the coordination of the central nervous system, the autonomic nervous system, and the endocrine system. So these are all required for the body to adjust, adapt, and maintain that equilibrium or the homeostasis. The brain and the spinal cord are kind of in control of all these things. Again, the general adaptation syndrome is a response to long-term exposure to stress. Homeostasis is not able to be maintained with the simple changes that your body does to try to keep things in check, eventually your body gives out to exhaustion and you end up with this general adaptation syndrome. Effects of stress. Stressors are not always bad, are they? Sometimes a little bit of stress keeps us healthy, keeps us on our toes. I don't remember who said this, but there was a famous quote that life without stress equals death. I want to say it was Shakespeare, but I'm not really good with the Shakespeare. It wasn't me, but somebody else came up with that quote. A stressor can be harmful or helpful, depending on the person's how you perceive the stressor. your degree of health and fitness to start with. If you're not healthy to start with, you're probably going to give in to the stress quicker. Previous life experience and personality. Some people are just survivors, and they've been through some things and they know how to keep on going and persevere. Other people, this may be their first really bad experience with the stress, and they may give in more quickly than others. Things like your social support can make a huge difference. People that are alone, unsupported, it's a lot harder for them to persevere and to keep going. But someone that has a strong family or a family unit or help, a strong system of support, they're going to persevere longer. And just the personal coping mechanisms. How do they deal with the stress? Do they eat a whole bunch of food and just sleep all the time? Or do they exercise and get those natural endorphins? How do they deal with that stress? What may cause a very mild reaction in one person can cause a much stronger and damaging reaction in another person. Coping with stress. We're going to come to coping. This is adjusting to or solving the challenges. There are 3 types of coping responses. Actions through thoughts that change the situation so it's no longer stressful. So actions, what do you do about it? Or thoughts, how do you think about it? I know this is a Shakespeare quote. Nothing is good or bad, but thinking makes it so. So if you think something is bad, it's probably going to manifest itself as bad if you just expect it to be. If something is, even it's a stressor or causes you a temporary inconvenience, if you see that as a healthy stressor and you recognize it as not necessarily bad and look at it as good, it could turn out good. So the way you think about it can make the difference. What do you do about the stressor? Alteration of thoughts to control the meaning of the situation before it triggers a stress response. So before it even causes your body to have a problem, how are you thinking about this stressor? That can make a big difference. Thoughts. Control of thoughts and actions to stop a stress reaction. You actually do have some control over this, but it has to be exercised, recognized, to be able to survive and have that resilience. Coping mechanisms help us to resist and master stressors. Ways to achieve coping responses are seeking information. Information is power. Taking direct action. Stopping an unhelpful reaction, like you break up with your girlfriend, boyfriend, and you drink a whole bunch of alcohol and then you're just sick the next day. Well, you don't want to continue down that path because that's not helping anything and it's actually making you sick. Discussing the situation with someone from your social support system, that would be a more healthy way to deal with this, depending on, of course, if they support you or not. Using defense mechanisms to perceive the situation differently. There again, changing the way you think about it can make a big difference. Defense mechanisms. So these are strategies that protect us from increasing anxiety. Boy, we need a lot of these days, don't we? We need to reduce the anxiety and secretions of the stress hormones. What do stress hormones do to our body? Long term, it can be very, very damaging. The cortisol release you've probably heard of causes that weight gain around the middle, causes us to want to eat that comfort food. Unconsciously, we're using defense mechanisms that give us time to solve the problem and adapt in a positive manner. So some people, their go-to is alcohol or overeating. Other people, they will exercise or do something constructive that will help them deal with the situation, but it's a more healthy response. This can be used to maintain and improve our self-esteem. This can be overused in a maladaptive way, these defense mechanisms. So it is possible to overexercise. Even though exercise seems like a good way to deal with things, you can overdo anything. Here's some examples of what we would consider poor mechanisms of dealing with stress, poor defense mechanisms. Every nurse has a responsibility to patients to promote better health through teaching about illness prevention, periodic diagnostic testing for cancer and diabetes, and safe practices. There are things like primary prevention, which is to avoid or delay the occurrence of disease or the disorder. Secondary prevention is follow screening guidelines, treat easily for easily treated diseases if they're found early. Tertiary prevention is rehab measures after the disease or disorder has stabilized. These are things we want to teach people before they turn to these defense mechanisms for help. How does exercise promote a sense of feeling of well-being and tranquility? It usually is through the release of endorphins. These are some ideas for stress reduction techniques that are considered more healthy. We've got things like progressive relaxation, where you progressively tighten and consciously hold and then release muscles systematically from top to bottom or inside out. Imagery, picturing yourself in a more peaceful place, kind of like a meditation type of thing. Massage, that physical manipulation of the muscles to cause us to relieve our stress and to relax. Biofeedback is another example. Some people like to do yoga, which is, specific poses that help us to relax and reduce our stress. Again, there's meditation and then just regular physical exercise. Not only does it relieve the stress immediately there, it also helps build up our resistance to stress, builds up our body so we don't succumb to the stress so easily. There is a group of people that get together, national group that's created by scientists that come up with the thing called Healthy People. They usually do this 10 years in advance of their expected achievement of these goals. This group comes up with goals or sets objectives for disease prevention and healthy promotion. So now that it's in the 2020s, our Healthy People goals are Healthy People 2030. You'll probably hear us refer to Healthy People 2030 as, that group of scientists that have gotten together and come up with these goals for the 2030s. So our regulatory agencies in healthcare, we've talked a little bit about the scope of practice and how the different states have their own nurse practice acts that regulate the practice of nursing and their scope of practice for each state. How about the larger agencies like the hospitals and the nursing homes, skilled facilities, home health agencies? These are going to be different groups. Of course, the federal government, they pass laws, but then each state has their own rules and regulations. You may or may not have heard of Joint Commission, which is the accepted group that sets the rules in place, and they will do inspections on the big facilities like the hospitals and long-term care and ambulatory surgery facilities. These regulatory agencies in healthcare enforce standards and practice requirements that play a major role in the quality and costs of care delivered. They're going to require things that may cost more money for the agency to provide, but they make sure that it's fair and the same across the board. PJC, or the Joint Commission, you're going to hear that a lot. This is an independent nonprofit organization that accredits a healthcare organization in more than 9 different types of healthcare settings. Like I said, it could be anything from hospital to ambulatory surgery centers, dialysis centers, home health agencies. The Joint Commission monitors state legislative and regulatory changes. They keep up to date with it, and then they make sure that the facilities are keeping up with the changes. So somebody that's in administration, it would behoove them to keep track of these changes before they happen and before the Joint Commission comes to their facility to inspect them and they're not staying up with the regulations and legislation that are currently in place. The Joint Commission publishes the National Patient Safety Goals annually, or the NPSG. They partner with other organizations to develop safe practice, identify the root cause of errors. You'll hear somebody say a root cause analysis, or RCA. That's when a terrible event happens or a sentinel event happens. They have to determine the root cause of that. They keep track of those, and then they make rules and regulations to try to prevent those from happening in the future. They create a system to mitigate future risk. When an organization loses their joint JTC or hospital accreditation, it's very expensive because then they don't get the reimbursement from Medicare and Medicaid or the government reimbursement that everybody needs to stay afloat financially. Insurance also follows suit when Medicare and Medicaid makes changes, or they no longer are, if the facility is no longer accredited and they lose Medicare and Medicaid accreditation, then the insurance company will follow suit as well, and they will not want their business to be going to those facilities since they're not staying current. Inspections by the Joint Commission are taken very seriously. Administration will come out of the woodwork when Joint Commission shows up to do an inspection, and they do not always announce before they come that they will hold you to that standard that's set. So the organization is given a set amount of time to make corrective action for things that are flagged or do not pass the inspection by the Joint Commission. And then the Joint Commission comes back in like a few months. They'll tell you like 6 months or 3 months and see that the appropriate changes are made. If those appropriate changes are not made and you failed the inspection, things are flagged and the changes are not made. If Joint Commission comes back and it's not corrected, then they can cause that facility to lose their accreditation. This is a very serious thing because of reimbursement. This is what I was talking about, sentinel events, the one that results in a client death or a permanent or severe temporary harm. These events are recorded to the Joint Commission and are tracked to help healthcare organizations improve their client care and quality of care. Sentinel events are sometimes called never events because these are events that should never happen, but sometimes they do. There's an ethical and professional obligation to report when these events happen. Quality assurance or quality control within the organization should be tracking these as well and then reporting them to the Joint Commission. These are really serious things that can happen. Things like an example would be maybe operating on the wrong body part, or somebody loses a limb because their circulation was not monitored correctly. What's another example? Never events, things that should never happen. Giving a lethal dose of medication that would, a normal person, a reasonable practitioner would not mistake, and somebody mistakenly gives a wrong dose or wrong med that causes death or harm. These are sentinel events that should not happen. They do need to be reported. What's a reason that people might not report these? For fear of blowback, for fear that they'll get fired. They don't want to get in trouble, so they'll try to sweep it under the rug. This is not a good idea. Obviously, it's not ethical as a nurse. If you give the wrong antibiotic and you're like, well, no harm was done, I just won't report it, that is not ethical. And you could be brought up on charges if you're discovered. So you need to report yourself or an event that happens like this. It is an ethical and moral professional obligation. The reason to file a report, and what I mean by a report, it's usually called an incident report. That incident report does not go in the chart, but the quality assurance people there in the facility will keep track of, like, maybe there's a really good reason for this mistake, and maybe multiple people are making the same mistake. It's not just to get the nurse or the professionals in trouble, but it's to cause a correction so that future events like that do not continue to occur. It's better outcome for the patient ultimately. Fee-for-service is a type of payment system. This is when the healthcare reimbursement system providers receive payment directly based on the volume of service they provide. This is not very common anymore. This is just paying out of pocket. Usually people have some kind of an insurance or Medicare or Medicaid. The traditional use of this model resulted in skyrocketing healthcare costs. This mostly was back in the 80s that it really started to inflate. This led the government to change from paying for volume to paying for value. So the way payment is determined now, they've got some different ways of going about it. Nowadays, we have Medicare for clients that are 65 years and older, or those that have permanent disability. There's different kinds of Medicare. There's Part A, Part B, Part C. Part A is pretty much for hospitalization, home health, and hospice. Part B requires a monthly premium to be paid by the client for coverage of outpatient and provider services and fees. Part C is a different part of Medicare or Medicare Advantage or a supplemental plan that covers Part A, B, and sometimes D. And by D, we mean medication coverage. It also requires a monthly fee. So when someone's on Medicare, they may be on Medicare A, Medicare Part A, B, and C, or Medicare A and D. It just depends on what services they want to make that extra payment, monthly payment for, to provide coverage for. It depends on their circumstances. Do they take a lot of meds? Do they have a lot of chronic illnesses? Or are they pretty healthy when they sign up for Medicare? Medicaid is for those that have permanent disabilities or underprivileged. They have to meet certain parameters for that Medicaid reimbursement of services. And then there's private insurance. Now, private insurance is something that we pay a monthly premium through our employer, usually to get the better deal. But that private insurance, they usually try to follow the rules that Medicare and Medicaid pay for reimbursement. We'll go a little more into that. The diagnosis related group, or DRGs, were something that came about in the 80s. It says it was created by Medicare in 1983. This was an attempt to contain rising costs of healthcare costs. A DRG, or a diagnostic related group, is a set amount of money that the hospital or facility will receive as reimbursement for a certain diagnosis. So it's a diagnostic related group of payment. When clients are admitted to an acute care setting, they're coded. They're given a code for their specific DRG or their diagnosis that they're admitted with based on their primary diagnosis, age, and their sex. So somebody with a heart attack will receive a certain code. Healthcare facilities receive a fixed reimbursement for each client based on their DRG. This rewards healthcare facilities that provide quality care in an efficient manner. If someone has pneumonia and that the payment is received for that diagnostic related group for the pneumonia treatment, and then they come back with worsening or reoccurrence of the pneumonia because they were not treated appropriately, the DRG can refuse to pay any further or refuse to pay the bill because it doesn't meet the terms of the diagnostic related group. Coding of the diagnosis makes a big difference in reimbursement. All of the pertinent diagnoses should be included. For example, if a person is admitted with pneumonia, they should also include if that patient is diabetic. This will make a difference as to whether or not they will recover as quickly or if they have complications due to that secondary diagnosis. So coding of the diagnoses are very important, and they're important to the reimbursement grouping or DRG. There's something else called a resource utilization group. This is talking about more of your long-term care facilities, how they're paid, the payment system used in long-term care facilities, where reimbursement is based on the client's diagnostic related group and the resources the diagnosis is expected to utilize. So somebody that's had a stroke, the long-term care facilities or rehab facilities will receive a set amount of money based on those diagnoses, what they expect or anticipate that care should require. If they go over the amount of services that are required, then that facility will possibly lose money if it's not coded correctly and they go over the amount. The client assessment is based on a minimum data set, which it evaluates the information such as the cognitive status of the client, their need for assistance with ADLs or activities of daily living, and the number of treatments and therapies that are being provided, as well as the disease and the diagnosis. Now we're going to jump to levels of care, levels of health care. This is this is on a spectrum as well. What do we mean by spectrum? Some of them kind of overlap. It's not always real cut and dried what's primary, secondary, or preventative and acute. And let me get into this a little bit more here. If you look on page 10, figure 1.10 of your Fundamentals, Concepts, and Skills for Nursing book, your Williams book, you can find this information. I'm going to flip to the page 10 here so I can tell you a little bit more. The healthcare system, levels of care, it's on the right-hand side, talks about preventative, primary, secondary, tertiary, restorative, and continuing care. Preventative care are going to be things like education and prevention, early detection and routine care. What are some examples of these? Let's see. The focus is to educate the client on reducing risk. Examples are promotion of immunization. So immunizing the well child checkups, that would be a good example. Healthy diet, nutrition, exercise, stress management, and safety. This might be going to your regular care provider on a regular basis to prevent having problems, regular checkups as a child or as an adult, well mother baby checks before a problem were to occur. This emphasizes the health promotion, patient education, disease prevention. Here it says the well child or well patient doctor visit, common community health centers, school or work health screenings, like the vision and hearing screenings that you have in the schools. These are forms of prevention or preventative care. Then it moves down the spectrum to secondary healthcare. This is when something actually happens, an acute illness or an injury. Examples are you have to make a visit to the hospital, have to be inpatient for something, maybe you have to have a surgery, have your gallbladder out, maybe an ER visit, something that's temporary, maybe you were in a car wreck and you hit your head, or you broke an arm or a leg, something that's kind of acute but temporary. An urgent care, maybe you're just acutely sick and you have to go to the urgent care on a Saturday because you can't get into the doctor's office and you're just really, really sick. So the illness has already happened and you need treatment immediately. This is a secondary healthcare. It's not preventative. And then finally, you've got your tertiary care. Tertiary care is also acute, but it involves more of a specialized or highly technical area. Say you had a heart attack, which is an acute illness, but then you have to go to the ICU for a while. Oncology center, say you've suddenly discovered you have a stage 3 or 4 cancer, and then you have to go to an oncology center. And that doesn't resolve real quickly. You have to have treatment for quite a while, and it requires specialized care. That would be a tertiary care. Maybe a burn center. Burns take a long time to heal. It's an acute illness, but it takes a specialized treatment. After the fact, you've got things like restorative and continuing health care. What do we mean by restorative care? Restorative care is going to be things like immediate follow-up after a surgery or rehab of some kind, like after surgery. You may need a rehab services or even home health care. Say you've had that stroke, you've recovered from the stroke, now you need to restore as much as you can to get back to a normal functioning or as much close to a baseline as possible. You may not resume all of your normal functioning, but you want to be as independent as possible. And then something like continuing care would be care that you're going to need chronically. Maybe this is a thing like a long-term care. They say it was an older person or somebody that fell and broke their hip. They went through all the stages, went to tertiary care, rehab, did as much as they could with rehab, but they just can't get back home. Maybe they're going to need some chronic or long-term care. So this would be like your nursing home, that they're permanently going to be there. They're not expected to go home and function more like normal. It's more of a chronic continuing care. Personal care, maybe hospice care. Maybe they're not going to recover. Maybe they can no longer do ADLs for themselves. These would be examples of them. Restorative care, here it says home health, rehab, and skilled. Continuing is more long-term chronic healthcare needs. Adult daycare. They can no longer be alone by themselves. They may need assisted living, nursing home, end-of-life palliative or hospice care. So hopefully we've touched on most of these things. Let's just review the difference between health and illness and the impact of lifestyle and risk factors. The terms health promotion, wellness, the nurse's role in supporting the client's journey towards optimal health, primary, secondary, and tertiary care, different types of care. So we decided primary was kind of preventative. It could be those well baby care, nutritional screenings, exercise class, family planning, emergency preparedness. It could be things like smoking cessation to try to keep the patient from getting worse and causing damage to themselves long term. School physical exams like hearing and vision, immunization programs, maybe just something like a blood pressure screening. That's a preventative or primary care. Then secondary care or the acute care, these are things like surgery, inpatient, emergency. This also includes restorative, rehab, physical therapy, speech therapy, occupational therapy, home health, and finally the tertiary care. This also includes a restorative and continuing care. This is kind of confusing because it's on that continuum. Again, I would refer you to see your book at page 10 and 11 of the Williams book. It's got the healthcare system, preventative, primary, secondary, tertiary care on the left side, and then it's got the box 1.2 that goes into more detail how those overlap. Hopefully we've given examples of those. Differentiate between the goals of acute and chronic care. Acute care, you're trying to get back to normal. Chronic care, you're going to achieve as much normal as possible and deal with it on a regular basis. Principles of restorative care and rehabilitative care. Restore back to the restorative or rehab is to get back as much as possible to normal. Contrast palliative and hospice care. Now, we really didn't touch on this. I would say that the difference here, just so you know, palliative and hospice, this is when somebody has a terminal illness. Usually palliative, just so you know, it focuses more on the quality. You're not going to be doing curative or trying to fix the problem anymore, but you could still get some treatments. Now, hospice care is pretty much, you've accepted it's the end and you want comfort measures only, but both of those are the same in as much as they're not trying to cure the situation. They focus more on quality. But hospice, to achieve hospice care, you have to be diagnosed with something that is technically terminal or less than 6 months expected lifespan. The role of the nurse in providing end-of-life care, we're going to see the loss, grief, and end-of-life PowerPoint that will be next. We'll go into more detail on that one. The various healthcare settings in which the client care is delivered, we kind of touched on those, and the role of the state and the federal government in regulating healthcare. So hopefully this has answered some of your questions. Of course, do your reading. This would be chapter 2, basically, in your book. And I would highly encourage you to read those and pay special attention to page 10 and 11 with the examples of the healthcare services and the levels of care. Thank you, and we'll see you in the next video.